Well, the first unmet need is to have a treatment that actually works and passes the muster for level 1 evidence from 1 or more clinical trials. We came close with clear, but just missed. Well, we think that earlier treatment is going to be important, and we found finally a signal that treating earlier is better. So we have to do things faster. I think the second thing is knowing what endpoints to go after. And we have lots of hypothesis generating evidence that the critical endpoint with brain hemorrhage is getting almost all of the blood clot out. The main findings were that when you use a policy of just adding TPA, low-dose TPA, into the intraventricular catheter, that you don't get all the blood clot out. The secondary findings were that we could alter mortality substantially, an absolute benefit of a 10% decrease in mortality at 180 and 365 days. We also found that the more blood clot you took out, the better the functional outcome of the patients was. So the primary endpoint of improving modified Rankin in all the patients was greatly softened by the fact that in the people who we actually performed what we thought we were performing, near total removal of blood clot, there wasn't an absolute benefit. Well, we found out a lot about measuring quality of life. The first thing we really found out is that any professional assessment of quality of life is limited a bit. We use both the modified Rankin, which was our primary outcome, and the extended GOS. We found a little bit more sensitivity to benefit in the extended GOS, which makes sense because the extended GOS has more levels of disability than the Rankin. But the other and more important thing we found is that you have to talk to the patient. And the stroke impact scale and the EuroQoL, which are patient-reported outcomes, showed a lot of sensitivity to benefit. And they also showed us that the patients who are categorized as Rankin 4 and 5, many of them are actually very happy with their situation and value it more than the professionals do, value it more than the physicians and other medical professionals who are making decisions about whether or not to render care. There were subgroups of patients who benefited. When we sliced and diced age, which is a very important factor, and old people tend to do less well with brain hemorrhage, just like everything else, we found that old people and young people benefited equally, which was counterintuitive. Besides this benefit across all ages, we also found the subgroup of patients with larger clots, those over about 20 milliliters of blood in the ventricle, benefited substantially. This makes sense because these are the people who we were able to remove the largest amount of blood from. And in that group, we found a statistically significant benefit at the modified Rankin 0 to 3 cut point, so that more patients actually were independent at home.